lifelike depression, and the clinical depression is something not that much palpable. So in this context, I welcome Dr. Malayappan sir to speak on the categories of depression and its impact on management. Over to Malayappan sir.
Morning, one and all.
Introduction.
Yes, sir. I'll start. Dr. M. Malayappan, sir has completed his MBBS from Tirunelveli Medical College and MD Psychiatry from Madras Medical College. Sir has a vast experience in the field of psychiatry for about 24 years. Sir has held clinical and teaching positions in many renowned medical colleges of Tamil Nadu, like Madras Medical College, Chennai, Raja Muthaiya Medical College, and Institute of Mental Health, Chennai, and many more. Sir is involved in teaching psychiatry to medical students, nursing students, postgraduate students in psychiatry since 1997. Has been an examiner in psychiatry for Tamil Nadu, Dr. N.G.R. Medical University and Kerala University and other private universities. Presented many guest lectures in state, zonal conferences and published papers. Sir is very unique for his admirable intellect in the field of forensic psychiatry and disability. His perspectives and opinion in this area are simply special and admiring. And most importantly, Sir is the current president of Indian Psychiatric Society Tamil Nadu chapter and chief executive officer of State Mental Health Authority Tamil Nadu. Sir, we are glad to have you as a chief guest speaker in Evolve Forum on the topic of categorizing depression and its role in treatment. Before entering into the topic, so I have a couple of introductions. So in every presentation, the speaker used to ask 3 to 5 questions to the participants, especially the postgraduate students. The people who are answering the correct answer in the chat box, the first 2 of them will be selected for the prize. Almost in the last 5 sessions, the first 4 session winners were already handed over the prize. For the last session, there are 5 people who answered very well in the questions asked by Dr. Narasimha. So they are Dr. Shamini from Tirunelveli Medical College, Dr. Mauri Deep from NIMHANS, Dr. Paulami Laha from NIMHANS, Dr. Monica from Madurai, and Dr. Sachin from Thrissur Medical College. So warm congratulations for all the winners. So in this session also, Sir will be asking 3 to 5 questions in between the session. So people who know the answer can answer in the chat box. The first 2 of them will be selected for the prize. So with that introduction, so I just hand over the online dais to respected Dr. Malayappan sir. So it's over to you, sir.
Good morning, one and all. I thank Dr. Panneerselvam, the post coordinator of Evolve program, and the moderators, Dr. Nurul Hassan and Dr. Aswath Babu, for being moderators, and they are the, fulcrum for Dr. Panneerselvam in organizing this Evolve program for PG students. And I thank my chairperson, Dr. Vidhu Kumar, for giving a nice introduction to the topic. And I thank all the postgraduate students who are attending in the Sunday morning. And I will try to throw some light on the categorization of depression and its role in the management. I will share my slides. Are you able to see my slides?
Yes, doctor.
Yes, sir. Yeah, it's visible, sir.
Okay. Categories are essential for medical science. Only when we categorize, we will be able to treat, we will be able to identify, we will be able to differentiate, and we will be able to treat them. So without categorizing any disorder, Maybe it may be typhoid fever or tuberculosis or bronchial asthma or malignancy or hypertension or diabetes mellitus. Unless we categorize them naturally, we will not be able to identify them. We will not be able to treat them effectively, and we will not be able to follow them. We will not be able to advance science in finding out the etiopathogenesis and cause and outcome of any disorder in medical science. Similarly, in psychiatry also, categorizing categorical model of psychiatric disorder is very essential. Without categories, we will not be able to diagnose, we will not be able to teach, we will not be able to treat, we will not be able to follow up our patients. So categories are very, very important in the field of psychiatry. And there are some pitfalls also in categorizing psychiatric disorders. There are some merits and there are some demerits in categorizing psychiatric disorders. And regarding depression, it is somewhat more, it has more merits and also more demerits in categorizing depression. And in the next 40 or 50 minutes, we will go through the categorizing depression and its role in the management. See, depression is traditionally classified as bipolar depression, unipolar depression. And in the unipolar depression, we have mild, moderate, severe depression. Depending upon the course, it is classified as a recurrent depressive disorder or a depressive episode, single episode. Depending upon the duration, it is classified as chronic depression sometimes. With the onset, postpartum onset, the characteristic features we can say it is psychotic depression, melancholic depression, atypical depression. With the pattern of recurrence, we can say it is seasonal depression. Again, clinical features, catatonic depression, anxious depression. And we have apart from this unipolar depression, we have adjustment disorder and dysthymia also. We'll be going through some of the categories, how they are formed and how they are helpful in the diagnosis and how they sometimes not very much helpful in the treatment of our patients. Subtypes and specifiers has been given in DSM. DSM provides an option to identify more homogeneous subgroups patients via subtypes and specifiers in a category. In a category, there are subtypes and specifiers. For example, in the category of attention deficit hyperactivity disorder, there are two subtypes. One is predominantly hyperactive impulsive subtype, and the other is predominantly inattentive subtype. These are mutually exclusive categories. And if a child qualifies for hyperactive impulsive category, it will not qualify for inattentive category. So these are called as subtypes. They are mutually exclusive, whereas specifiers are not mutually exclusive. For example, seasonal affective depression and atypical depression. A seasonal affective depression can also be called as an atypical depression, can have features of atypical depression. They are not mutually exclusive. So something which is not mutually exclusive are called as specifiers. Something which are mutually exclusive are called as subtypes. So these subtypes and specifiers are mentioned in the DSM whenever categories are defined or operationalized. So how far this is helping or this is implemented in depression, we will go through. Before that, we will go through some historical aspects in categorizing depression. See, for the diagnosis of major depressive episode, DSM differentiate between diagnostic categories. It has been specified as bipolar versus unipolar, depending on the illness history, recurrent versus single episode, and symptom severity, mild, moderate, severe depression. And also 9 different specifiers for course or symptom presentation. Example, catatonia with anxious distress with melancholic features. These are all course specifiers, and we'll go through them. See, in the 1960s, as our chairperson sir has rightly pointed out, depression before 1960s, it was dichotomized as psychotic depression and neurotic depression. And in another way as endogenous depression and reactive depression. Psychotic depression is almost synonymous with endogenous depression, and neurotic depression is almost synonymous with reactive depression. This dichotomy of depression is not agreed by agreed by many psychiatrists later on. The psychotic depression or endogenous depression used to describe presentation with acute and severe depression, psychomotor retardation, diurnal variation, weight loss, and severe insomnia. The neurotic or reactive depression with symptoms of chronic depression with anxiety, self-pity, and anorexia, which was related to stressful life events. However, a proportion of episodes of endogenous depression were precipitated by stressful life events also, and made such differentiation complex. Even some of the endogenous depression or psychotic depression are precipitated by exogenous factors like a loss of a loved one or any stressful life event. So endogenous depression also can be precipitated by stressful life events. Some argued that such divisions were only separating mild from severe disorders. These two dichotomized psychotic and neurotic depression or endogenous and reactive depression are only expressions of mild to severe dimension. So later on, after 1960s, these terms were outdated and were not used by the contemporary psychiatrists. These terms were died, I would say. Death of these terms was a result of multiple meanings prevalent in literature and difficulties in precisely defining them. The reason is in 1970 saw major changes in psychiatric diagnosis. The US-UK diagnostic project major inconsistencies in transatlantic diagnosis. The patients which were diagnosed as depression with psychotic symptoms in UK were more likely to be diagnosed as a case of schizophrenia in the United States. See, this project has resulted in realization that the urgent need was to improve the inter-rater reliability of psychiatric labels. Whatever being diagnosed in any part of the world should be diagnosed in the same way in any other part of the world. So this is what learned from the US-UK diagnostic projects. There was a lot of variability in making the diagnosis among the psychiatrists. In different universities, in different schools of thought, they make the diagnosis differently. So they tried to operationalize the criteria. Operational criteria for diagnosis was first introduced by Feiner et al. In 1972, were a major advance and caught the imagination of the psychiatric community. Till then, the reliability was not there in the field of psychiatry. In one university, the patient may be diagnosed in a particular way, whereas in another university, the patient or another hospital, the patient may be diagnosed differently. So Feiner introduced in 1972 operational criteria for psychiatric diagnosis. DSM-3, which was published in 1980, adopted this Feiner's approach of operational criteria. These criteria sidestepped much of the controversy related to categorizing depression and focused on reliability. But as a side effect, the roles of stress and coping styles were discounted, and the new scheme with its descriptive approach, operational criteria, and emphasis on reliability seemed to have firmly placed many unresolved issues on the back burner, and it became a new standard. The etiology was discarded. The ICD and DSM become atheoretical. They don't consider the etiology of the psychiatric disorders. It is only the operational criteria, duration criteria makes a diagnosis in a descriptive way. So that happened after 1980, after DSM-3. Operational criteria became the norm in psychiatric practice. The current position, DSM-5 and ICD11, continue the same approach. The traditional categories of melancholia, endogenous depression, dysthymia, neurotic depression, and adjustment disorder, reactive depression, are retained in DSM and ICD in different forms as a specifier, as a dysthymia, as another category, another type, an adjustment disorder as another category. These are all retained, but how far it is utilized is questionable. The reason is the major depressive episode of DSM-5 straddles all three conceptual categories. A patient who had depressive symptoms because of a stressful life event, if he qualifies for a depressive episode, he will not be qualified for adjustment disorder. He cannot be diagnosed as adjustment disorder. So The concept of reactive depression, I would say it is buried in the concept of major depressive episode. And again, here melancholia, the concept of melancholia also can be diagnosed as major depressive episode in DSM-3. So, major depressive episode as a category which represents severe depression, which can be seen in people with poor coping and or with precipitating stress. That is dysthymia or reaction to stressful life events, reactive depression, or an endogenous depression, all get submerged in the category called as major depressive episode. This ultimately turns the dichotomy or binary concept of depression to unitary concept of depression. Depression is considered as a single entity without the dichotomy of psychotic, neurotic, or endogenous reactive. This happened in 1980 and followed till today. Till today, we are practicing depression as a single entity. We don't consider it as a two diagnosis, as endogenous reactive or psychotic neurotic. ICD went a step further and subclassified the depressive episode into mild, moderate, severe based on the symptom count. So ICD introduced this concept of subdividing depression into mild, moderate, severe. The symptom thresholds for mild and moderate depressive episodes were reduced. Consequently, the criteria for such episodes are usually satisfied by people who present with acute stress-related problems. Someone failed in the exams, someone lost their love, someone lost their business, someone had an injury. All these stress-related problems may be present for a month or two, self-limiting. They can be diagnosed as a mild depressive episode according to ICD-10 or DSM. And also people with chronic depression will qualify for these mild depressive episodes. And then came the concept of double depression. Personality problems leading to a chronic depressive state can also be diagnosed as a mild depressive episode in ICD and DSM. Now I'll ask question number 1, and I'll just ask the question and I'll move on. DSM-5 describes 9 symptoms of major depression. ICD-11 describes 10 symptoms of depressive episode. Which is a symptom which is not included in ICD-11, which is included in ICD-11 but not in DSM-5? That is a question. What is a symptom which is included in ICD-11 but not in DSM-5? The category of major depression had a significant impact on classifying and treating depressive disorders. We'll see how it influenced the treatment of depression. See, the ICD-11 prolonged grief disorder recently introduced. The draft came in 2016, maybe 16 or 17, and DSM-5 came in 2013. So they compared the prevalence of prolonged grief disorder according to ICD-11 and persistent complex bereavement disorder according to DSM-5. And they found when ICD-11 is used, the prevalence is 18%. And when DSM-5 is used, the prevalence is 6.4%. Almost there is a 3-fold increase in the diagnosis of prolonged grief disorder. When you decrease a threshold or increase a threshold, it influences the prevalence of psychiatric disorders. This is particularly true in depression. See, I will give you an analogy. When you have 140 as a blood pressure level for hypertension, and suddenly one day you reduce it as 130 millimeters as hypertension, then enormous number of lakhs and lakhs of people will be called as hypertensive patients. Previously considered as a normal individuals will be categorized as people with hypertension. So when the threshold is reduced, when the threshold or the criteria are changed, it can make a profound impact in the prevalence of psychiatric disorder and hence the treatment of psychiatric disorder. So in sum, it is unclear how the introduction of ICD-11 will influence the prevalence rate of mental disorders. It will be known only in the next few years how the changes in ICD11 is going to influence the prevalence rate of mental disorders and therefore treatment. Current classification system of mental disorders are based on polythetic categorical approach. In this classification system, list of characteristic symptoms is provided for each diagnosis. The presence of a usually predefined number of symptoms from the list is sufficient to assign the respective categorical diagnosis. Categorical diagnoses are required to justify treatments, to communicate efficiently about mental disorders, and to collect epidemiological data. A categorical diagnosis may aid in the decision whether to treat or not to treat the patients. However, the categorical classification of mental disorders is associated with various limitations including large within category heterogeneity. If you take 100 patients with major depressive episode, they will not be similar. They cannot be similar each, or they will have different presentation. That is very well known in psychiatry. Within the group, there is a marked heterogeneity among the patients who are diagnosed as a single category. And because of that, because of these categories, we end up with a lot of comorbidity. Patients with major depressive episode are also qualifying for generalized anxiety disorder. Like that. So these heterogeneity, comorbidity, and difficulties in representing subthreshold symptomatology. These are all the demerits or minus points of categorical classification. That not only that, the subsequent research in major depressive episode found that there is functional hypercortisolemia, altered intracellular signal transduction, and protein activity in the central nervous system. The biological research for the last 40 years have come out with many biomarkers or biological changes in patients with major depression, unfortunately, and even structural abnormalities in the brain have been reported. Unfortunately, these findings remain preliminary because of the lack of unequivocal replication and failure to control for potential confounders and comorbid conditions. We were not able to declare that these are all the biological changes in depression, even though we have found something that has not been translated to clinical practice. That may be due to the way in which we categorize, operationalize diagnostic criteria. When we include different groups of patients into one category, then we will not be able to replicate the biological findings. So this aim of humanity to find out the biological basis of depression is hindered, I would say, is hindered by the way in which it is being categorized and operationalized. The inability to identify specific biological markers to diagnose individuals with major depression. The failure of such abnormalities to differentiate major depression from other psychiatric disorders. Although average differences between groups may exist, if you take 100 patients, another 100 patients of controls, you will find group differences. But the marked heterogeneity among the 100 patients of depression does not allow for the recognition of individuals with this condition using biological markers. This is one of the demerits of the categories we have in psychiatry. Group differences exist, but that cannot be used for individual diagnosis. After 1980s, when this operational criteria became the norm, pharmaceutical industries started benefiting a lot. The pharmaceutical industry quickly adopted major depression as a standard for testing all antidepressant treatments. Fluoxetine was introduced in 1988, and other selective serotonin reuptake inhibitors followed, and they were found to be effective. Their usage in clinical practice increased as they did not have the troublesome sedative or anticholinergic side effects of the older tricyclics. Antidepressants became the treatment of choice for depressive episodes. There was neither a need to speculate on the role of precipitating stress and coping strategies, nor the requirement to manage them with the psychotherapy. Fluoxetine became the panacea for loneliness, relationship difficulties, interpersonal conflicts, inability to cope with day-to-day stress and the like. Major depression was equated with the biological disease, and focusing on its causes was considered old-fashioned. Causes means etiological theories like psychodynamic or cognitive behavioral. Those causes were given less importance after 1980s when fluoxetine came to the picture. Why would anybody spend time on psychotherapy when these wonder drugs were said to elevate the patient's mood, irrespective of its cause and context? The choice of medication by the late 1990s was enormous. Fluoxetine, sertraline, paroxetine, citalopram, fluoxamine, venlafaxine, reboxetine, mirtazapine could be used in sequence and occasionally in combination with older antidepressants and benzodiazepines. At that point, medicalization of distress was complete. This is by Jacob John from CMC Vellore. After 1990s, this happened, but the story does not end here. After 2000, we have some other findings. We have new findings. Major depression, spontaneous remission, and placebo response. After the late 1990s and early 2000, we had the findings. Research into major depression supports the argument that there is a high rate of spontaneous remission. Many others have highlighted the high rate of improvement in placebo arms of randomized trials employed to test the efficacy of antidepressant medication. Fluoxetine or sertraline are as good as placebo. That was a finding from meta-analysis. So the validity of the diagnosis of depression is questioned by the society. When it is responding to placebo, what is the need for giving SSRIs? A meta-analysis by Krish et al. Found no evidence that SSRIs are efficacious for milder forms of depression. The precise implication of the evidence related to the value of antidepressant is debated, with others arguing for small or medium effect sizes rather than a complete absence of efficacy. We have to defend ourselves with studies to say there is a small or medium effect size in mild forms of depression, when the finding of placebo is as good as antidepressants came in. So I'll ask the question number 2. What is the difference between subtype and specifiers in DSM-5? What is the difference between subtype and specifiers in DSM-5? And I will go to the category of adjustment disorder. This is important and how it is being neglected. Although the diagnosis of adjustment disorder is retained in the ICD and DSM, it is eclipsed by the focus of disorders among researchers, policymakers, consequently among clinicians. Many people do not make a diagnosis of adjustment disorder because the symptoms qualify for diagnosis of depression. There is an exclusion criteria in the criteria of adjustment disorder. They should not qualify for another psych.
Doctor, kindly unmute it, doctor. We lost you. The mic is muted.
Malayam sir, unmute sir.
Okay, I have unmuted. Are you able to hear me?
Doctor.
Yes, sir.
Yes, doctor.
Fine, sir.
Okay. See, when a patient qualifies for major depressive episode, we cannot make a diagnosis of adjustment disorder. And the criteria for major depressive episode, mild depressive episode has been lowered. So the adjustment disorder as a category has been mostly neglected by researchers, policymakers, and clinicians also. Then academics also have neglected the category and have failed to examine into the large epidemiological studies like the epidemiological catchment area, a national comorbidity survey in the USA, and the national psychiatric morbidity survey in the UK. They don't even include adjustment disorder in the list of disorders to be surveyed. The stress-related disturbance does not meet the criteria for another mental disorder, is not merely an exacerbation of a pre-existing mental disorder. This is the condition for making a diagnosis of adjustment disorder, both in ICD and DSM. When you say does not meet the criteria, when the criteria are met for major depressive episode, we cannot make a diagnosis of adjustment disorder. It is considered as a somewhat milder form of depression, less than mild depression, related to a stressful life event. The concept of neurotic depression is submerged within the concept of a depressive episode. That's what I want to highlight. Instruments used to assess common mental disorders in primary care, for example, revised clinical interview schedule and the composite international diagnostic interview, failed to consider adjustment disorder as a diagnostic label. The marginalization of adjustment disorders in clinical practice is due to the elastic concept of depression and the rigid application of diagnostic hierarchy and criteria. When you make a diagnosis of major depressive episode or depressive episode according to ICD-10, you cannot make a diagnosis of adjustment disorder. That is the diagnostic hierarchy built in DSM and ICD. This has almost make the diagnosis to be neglected. We uncommonly or very rarely we make a diagnosis of adjustment disorder because most of the people will qualify for, those who come to the hospital will qualify for a depressive episode, mild. As Cassie and colleagues noted, the diagnosis of adjustment disorder implies a short-term problem which is highly likely to remit spontaneously. Such conditions have a high placebo response rate, but also respond well to supportive approaches focusing on stress management. Supportive approaches, self-limited. So when you include this adjustment disorder as depressive episode, they will have a very high placebo response and it will corrupt our biological research as well as treatment risk, random RCTs, and so meta-analysis. So when adjustment disorders are included in the category of major depressive episode, it will have an impact on the results. We will get results, placebos and fluoxetine are equally efficacious.
So the video is stuck.
Sir, doctor's bandwidth is not strong. So I think shortly it will be resumed, sir.
One could address poor coping strategies and lifestyle changes instead. That is what I want to insist. These three categories. Am I audible?
Yes, sir. Yes, sir. Audible, sir. Go ahead, sir.
Okay. These three categories, adjustment disorder, dysthymia, major depressive episode, are important to remember in planning the treatment for depression. Patients who present with melancholic features require antidepressants. Patients with good premorbid adjustment and symptoms associated with stress respond to supportive psychotherapies. Mild depressive episode can be treated with psychotherapy alone. That's what some of the guidelines tell now. Patients with long-standing maladaptive patterns of behavior and chronic depression require psychological interventions that aim to change attitudes, coping strategies, lifestyle, and philosophy. This is biological treatment, this is social treatment, and this is psychological treatment. So when there is impairment in patterns of behavior and chronic depression, that may require more of a psychological interventions which aim to change attitudes, coping strategies, patterns of thinking, lifestyle, and philosophy. When there are social problems, supportive therapies, and for some patients, antidepressants. So this differentiation in treatment is not there with the diagnosis of major depression. All categories of major depression are treated equally with one antidepressant. That happened. That is the reason. I'll come to that later. Psychiatrists and psychotherapists readily acknowledge that recovery in dysthymia depends more on the patient's personal resources and available social supports than on antidepressant medication. These issues have resulted in confusion about the validity of diagnostic category of major depression. Again, Jacob John from CMC Vellore in 2003. It's not only the high rate of response to placebo. They have reported high rate of placebo response, but the marked heterogeneity of symptoms. No two depressive patients will look similar. The variation in the clinical patterns, context, personality, stress, coping strategies, coping methods, treatment response, course, outcome. There are enormous variation in the category of major depression. That questions the validity of the diagnostic category of major depression. There is enormous heterogeneity of everything. So these are the implications of the atheoretical nature of classification of depression. Despite the claims that the current classifications are atheoretical about etiology and possibly to pathology, the category of adjustment disorder clearly acknowledged the role of stress in the production of depressive symptoms. Similarly, the roles of stress, coping, and personality traits in the maintenance of chronic depression are difficult to discount. We cannot discount the etiological role of stress and personality traits and coping strategies in dysthymia and adjustment disorder. The need for antidepressants and/or electroconvulsive therapy in the treatment of melancholia also highlights that different diagnostic headings are not mere descriptive categories, but refer to dissimilar conditions with the differing etiology and pathology requiring specific treatments. But these things are not considered even today. We consider depression as a single entity, major depressive episode or recurrent depressive episode, and treat them. And the classificatory system, categorization, this does not give a guidelines for the treatment. These atheoretical approaches to classification may have removed the strange hold of many theories, but their disadvantages in the context of depression argue for a more pragmatic approach. There is a need to refocus on the classic typologies of depression. The role of precipitating stress, coping strategies, and personality traits in producing and maintaining adjustment disorder and dysthymia respectively needs to be emphasized. The trend to decontextualize depression and other psychiatric disorders and universalize their criteria using a symptom checklist operational criteria may improve reliability, but only at the cost of validity. That was lately understood. So now we'll go to some of the categories or some of the specifiers, subtypes. There has been a long-standing view positioning melancholia as a distinct type of depression that appears more biological and which has been variably termed as endogenous, endogenomorphic, autonomous, vital, type A, as well as melancholic depression. The arguments in favor of its distinct status have included a somewhat distinctive pattern of symptoms and signs, a greater relevance of genetic and other biological as against psychosocial determinants. Long-standing binary view positioned such a depressive episode as distinct from second-type variably termed neurotic or reactive depression in terms of clinical symptoms and preferential causes. But despite some consistency in the clinical symptoms long listed as having some specificity to melancholia, in 1950s, the advent and application of differing multivariate analytic approaches in the psychiatry, that may be factor analysis, cluster analysis, or latent class analysis, failed to deliver support for a clear-cut symptom-defined binary solution. That is one reason why endogenous depression and reactive depression are considered as a single entity in DSM in 1980. Factor analysis failed to deliver it as two types. Now, question number 3. Which drug is claimed to be more effective in preventing seasonal depression? Which drug is claimed to be more effective in preventing seasonal depression? Melancholia, concomitant evidence of biological dysfunction, particularly involving the hypothalamic pituitary adrenal axis, a differentially stronger response to physical treatments such as antidepressant drugs and electroconvulsive therapy than to psychotherapy, and a low placebo response rate. Some studies have suggested that patients with melancholia respond better to tricyclics than to SSRIs and are particularly responsive to ECT, but this differential response has not been consistently confirmed. That also has to be agreed. Melancholia better response to tricyclics than SSRIs is not consistently confirmed. This finding was an earlier finding, but I would say studies were not replicated in that angle. The role of clinical characterization of depression will go to personalization of management. See, when we see a patient, whether we can somehow identify some of the clinical features and tailor our treatments accordingly so that the outcome will be better. That is called personalization of management. So far, we don't have any guidelines for personalizing the treatment of depression. We make a diagnosis of either adjustment disorder or depressive episode, mild, moderate, severe, without psychotic symptoms, or with melancholic features, or with catatonic features, and we start the treatment. We don't have guidelines to personalize the management of depression. This clinical features, this treatment will be better. We don't have any reliable guideline for personalization of management. Depression is widely acknowledged to be a heterogeneous entity, and the need to further characterize the individual patient who has received this diagnosis in order to personalize the management plan has been repeatedly emphasized. But there is a need. However, the research evidence that should guide this personalization is at present fragmentary. Now we have some research findings coming after 2010, 2015, 2020. We have some studies which aid us in personalization of management. We'll see some 2 or 3 studies and then we'll conclude. The selection of treatment is usually based on the clinicians and or the patient's preference and on safety issues in a trial and error fashion, paying little attention to the features of the specific case. This may be one of the reasons why most patients with a diagnosis of depression do not achieve remission with the first treatment they receive. This is one of the reasons in STAR D, there is only 30% of remission rate after 12 weeks of treatment with one antidepressant, clinicla. We are not able to personalize the treatment of depression. All patients who are diagnosed as depression, we give one antidepressant, wait for 6 weeks. And if that antidepressant is not working, we are supposed to switch to another antidepressant, or we are supposed to increase the dose of antidepressant. So we don't have any idea about how to tailor which patient will be better with which type of treatments. So we have a high 70% of, in study, they say in after 12 weeks, 70% of patients do not have remission at the end of 12 weeks, 3 months. The pessimism about, then exists a pessimism. We were not able to find out the clinical features or characters in the history or anything, any biomarkers. We are not able to personalize the treatment of depression. This pessimism about the feasibility of the personalization of treatment of depression in routine clinical practice has recently been shaken by some secondary analysis of databases of clinical trials using approaches such as individual patient data meta-analysis and machine learning. Some variables may indeed contribute to the identification of patients who are likely to respond differently to various antidepressant drugs and to antidepressant medications versus psychotherapy. Some clinical features, some parameters can identify which patient will respond to which treatment in a better way. That is personalization. So the symptoms included in the most frequently used rating scales of depression exceed in number those included in DSM-5 and ICD-11. HAM-D, MADRS, Beck Depression Inventory, CS, Center for Epidemiological Studies Depression, Quick Inventory of Depressive Symptoms, the Inventory of Depressive Symptoms, and Zoom Self-Rating Depression Scale. I will show you ICD-11 has 10 symptoms, DSM-5 has 9 symptoms. So hopelessness about the future is a symptom which is included in ICD-11 but not in DSM-5. And Hamilton Depression Rating Scale rate anxiety, irritability, somatic complaints, which are not considered as symptoms, which are not considered in the criteria either in ICD-11 or DSM-5. And also MADRS, we have anxiety. Anxiety is rated, but it is neither included in ICD-10, ICD-11 or DSM-5. So Beck Depression Inventory, we have irritability and somatic complaints. So these rating scales add some symptoms which are actually not included in the international classification system. Symptom profile. because reliability was given importance in ICD and DSM than the validity. That is the reason. There is a need for a tool covering the whole range of depressive symptoms beyond the list provided by the current diagnostic systems and probing the presence of these symptoms using multiple questions and subjecting them with different newer statistical methods, including machine learning. The identification of meaningful clusters of symptoms, once again beyond the DSM-5 and ICD-11, should be encouraged. The exploration of the relationship of individual symptoms or validated clusters of symptoms, the response to different treatments for depression should be identified as a research priority, requiring large patient samples, that is pooling results from different studies using the same assessment instruments and innovative approaches in data analysis. Then we will be able to progress in personalization of depression treatments. So a more recent analysis reported 3 clusters: core emotional symptoms, sleep symptoms, and atypical symptoms, including psychomotor agitation, psychomotor slowing, suicidal ideation, hypochondriasis, and reduced libido. We'll go through these studies a little bit in detail. See, this is re-evaluating the efficacy and predictability of antidepressant treatments, a symptom clustering approach, published in 2017. When evaluated according to aggregate measurements, total score of a scale, the treatment efficacy is generally modest and differences in efficacy between antidepressant therapies are small. We don't find any difference when the aggregate measurements are used. So, in this study, they have taken STAR-D trial data and also COMET trial data. And these findings, these symptom clusters, which have been identified in STAR-D, has been replicated in COMET trial also. So they have total, from both the trials, they have 4,706 patients and 7 additional placebo and active comparator phase trials of duloxetine. These outcomes have been reported. When newer statistical methods are employed to the older data, STAR-D and COMET, these are all 20 years or 10 years old data, they found that 3 symptom clusters were identified at baseline STAR-D. These 3 symptom clusters were replicated in COMET also. The antidepressants in general, 8 of 9 treatments, were more effective for core emotional symptoms than for sleep or atypical symptoms. So we have some finding that antidepressants were more effective in core emotional symptoms. Differences in efficacy between drugs were often greater than the difference in efficacy between treatments and placebo. For example, high-dose duloxetine outperformed escitalopram in treating core emotional symptoms. HAM-D points during 8 weeks, but escitalopram was not significantly different from placebo. The 2 common checklists used to measure depressive severity can produce statistically reliable clusters of symptoms. These clusters differ in their responsiveness to treatment both within and across different antidepressant medication. Selecting the best drug for a given cluster may have a bigger benefit than that gained by use of an active compound versus a placebo. So we have some findings pointing or moving towards the goal of personalization. Future studies will be required to bring it to the clinical practice. So same thing, antidepressant medications can be selected to the benefit of selective specific cluster of symptoms in depression. The same study. Same thing. This was by Chuck Broad in JAMA in 2017. Antidepressant medication in general has been found to be more effective in treating core emotional and sleep symptoms than atypical symptoms, with high-dose duloxetine being superior to escitalopram in treating both emotional and atypical symptoms. Observed in another study, observed mood and cognitive symptoms improved more with escitalopram than nortriptyline. Neurovegetative symptoms improved more with nortriptyline than with escitalopram. This in 2009. So some studies are there. some analyses are that previous data, when subjected to newer statistical analysis, including machine learning, we are getting newer findings that some symptoms respond to some drugs in a better way than some other drug. This data will help us in the future to personalize the treatment of depression so that we can identify the patients and tailor the treatment in the beginning itself. Overall, some evidence seems to support the notion that the symptom profile beyond the diagnosis of depression may have value in predicting the response to specific antidepressants or to antidepressant medication versus specific psychotherapies. However, this evidence is at present preliminary. Individual clinical trials have usually focused on the equivalence rather than the differences between the various treatments. In secondary analysis of databases using innovative techniques are just starting to emerge. Now we'll move on to bipolar, unipolar. This categorization, every one of you know, we have to treat differently bipolar depression than unipolar depression. And there are screening questionnaires for identifying, screening for bipolar depression whenever we see a patient with a depression. In this point, a second widely accepted subtype is psychotic depression, defined by the presence of delusions or hallucinations during the depressive episode and the lack of persistence of psychotic symptoms outside the period of depression. In patients with recurrent episodes of depression, the psychotic features tends to recur, but there are several patients with recurrent depression in which some episodes are psychotic and some others are not. Again, supporting the DSM-5 and ICD11 approach of regarding psychotic features as a specifier to the diagnosis of depression, rather than considering psychotic depression as a distinct disease entity. Psychotic features in depressed patients are associated with increased suicidality, particularly during acute episode, increased mortality from physical causes, and a poor outcome. Because of these treatment implications, it is important for clinicians to recognize psychotic symptoms in depressed patients. A Cochrane library review concluded that combination treatment with an antidepressant and antipsychotic is superior to monotherapy with either agent alone or placebo in psychotic depression. This has been an established fact. I think this is the only established fact in guiding the type of depression with the treatment of depression. Mixed depression, a further subtype of depression introduced for the first time in DSM-5 but not included in ICD-11, is mixed depression. This subtype has been defined in varying ways in the literature. So manic symptoms are simultaneously present. This definition has been criticized because it does not include features that have been considered as typical of mixed depression, such as psychomotor agitation, irritability, and distractibility. Okay, DSM-5 requires the presence of at least 3 manic hypomanic symptoms out of the list of 7. The presence of manic or hypomanic symptoms during a depressive episode is associated with a higher rate of anxiety and substance use disorders, increased suicidality, greater impairment in functioning, more frequent family history of bipolar disorder, poor response to treatments. So we have to watch for emergence of activation, hypomania, and suicidality whenever we treat mixed depression. An expert panel of mood disorder researchers, while acknowledging the limited number of prospectively designed trials for depression with mixed features, recommended atypical antipsychotic medication as the first line of treatment for mixed depression. So this is another guideline or another idea to say that categories of depression guides the treatment of depression. Anxious depression, this subtype of anxious depression has been introduced in DSM-5, though the specifier with anxious distress is also present in the ICD-11 with prominent anxiety symptoms. The DSM-5 specifier requires the presence of at least 2 out of a list of 5 symptoms: feeling keyed up or tense, feeling unusually restless. Okay, we'll move on. Patients with anxious depression are characterized by higher levels of suicidal ideation, poor functioning, poor health-related quality of life, and greater chronicity. Co-occurring anxiety has been reported to be a predictor of a poor response to antidepressant treatment in general or to specific antidepressants. We do not have any guideline to tailor our treatment to anxious depression. We can say that it's a poor response to antidepressant treatment in general. Atypical depression has been gained importance since 1980s. Mood reactivity, sensitivity to rejection, extreme energy, reverse vegetative features of increased appetite and increased sleep In controlled treatment trials, they found that patients meeting this subtype responded better to MAO inhibitors than to tricyclic antidepressants. The atypical depression subtype of depression entered DSM-4 and was retained in DSM-5, but not in ICD-11. Atypical depression is not found in ICD-11. However, monoamine oxidase inhibitors are no longer widely used. Evidence that patients with atypical depression respond better to MAOIs than the newer generation medication has been lacking. A recent meta-analysis found that atypical depression did not predict or moderate the response to either CBT or antidepressant medication. Seasonal depression. This subtype of seasonal depression is based on lifetime pattern of depression, more occurring in autumn, winter onset, and spring, summer as a resolution. Characteristic symptoms of winter depression are hypersomnia, hyperphagia, and carbohydrate craving. Consistent with the hypothesis that seasonal depression is the result of reduction in daylight hours, some epidemiological studies have found that prevalence rate are increased in northern latitudes, though the results have been mixed. Bright light therapy is an effective treatment for symptomatic seasonal depression. The recurrent pattern of this type depression provides a unique opportunity to examine preventive strategies. 3 Cochrane library reviews concluded that bupropion XL is effective in preventing seasonal recurrence. The evidence is insufficient to recommend either psychotherapy or light therapy as preventive interventions for seasonal depression. Bupropion XL is effective in preventing seasonal recurrence. Severity. The severity of depression has been associated with health-related quality of life, impairment, suicidality, longitudinal course and response to treatment. There are no biomarkers of depression that characterize disorder severity. Thus, researchers and clinicians base their severity ratings on the clinical features of the disorder. Almost all research on severity depends on depression rating scale, MDR, MADRS, or any other scale. In DSM-5, depression is classified as mild, moderate, or severe based on number of symptoms, the level of distress caused by the intensity of the symptoms, and the degree of impairment in social occupational functioning. The definition of functional impairment is limited to social or occupational functioning and does not include other potentially important areas of functioning such as self-care, parenting, or schooling. So these are the ways in which depression is graded in DSM-5. Few, if any, substantially excess that required. DSM-5 does not explicitly define moderate depression other than to say that number of symptoms or intensity and or functional impairment are between mild and severe. The intensity of the symptoms is seriously distressing, severe depression. The intensity of the symptom is distressing but manageable, and the symptom result in minor impairment in functioning, mild depression. Question number 4, whose operational criteria is a model or pioneer for the concept of operational criteria in DSM-3 in 1980? Whose operational criteria is a model or pioneer for the concept of operational criteria in DSM-3 in 1980? ICD-11 mild depression requires that none of the symptoms are intense. Moderate depression, marked intensity. Severe depression requires that many or most symptoms are present to a marked degree and some symptoms are intense degree. So these are the ways in which ICD-11 classifies mild, moderate, severe depression. See, this impairment threshold has some confusion. As with the DSM-5, there are potential problems with the logic of these definitions. For example, how should we classify a patient with symptoms of moderate intensity who is unable to work? As far as symptoms are concerned, it may be moderate. Impairment is concerned, it may be severe. Despite potential problems in applying DSM-5 and ICD-11 definitions for mild, moderate, severe, it gives more importance to more intuitive appeal to clinicians than severity classification based on depression symptom scales, because they consider the degree of impairment as co-equal to symptom level. However, there is almost no research on DSM and ICD definition of mild, moderate, severe. All the severity related guidelines are based on rating scales like HAM-D, MADRS, and other scales. There are no studies finding are aimed at the including the DSM ICD definitions of mild, moderate, severe. It is also noteworthy that neither DSM-5 nor ICD-11 consider suicidality in the definitions of severity. This contrasts with many physical illnesses. DSM and ICD definitions of depression severity has not been used in treatment studies. Only rating scales are used. So, and again, one point, adding all the item scores to yield a total score as a measure of overall depression severity assumes that all symptoms are equal indicators of severity, an assumption which is not empirically supported. Anhedonia, insomnia cannot be considered at par with each other, but HAM-D and MADRS considers some at par with each other and measures the severity. NICE guidelines discourage the use of antidepressant medication as an initial treatment option for mild depression, whereas recommend it along with empirically supported psychotherapies for moderate and severe depression. NICE guidelines is the only guidelines which says that antidepressant medication should not be considered for mild depression. The third edition of American Psychiatric Association guidelines recommends either psychotherapy or pharmacotherapy for mild and moderate depression and pharmacotherapy for severe depression. See, this is what severity is graded in the Hamilton scale. Approximately 2 decades ago, 2 analyses of US FDA database found that drug placebo differences were largest in antidepressant trials with the highest mean baseline severity. When we see more of severe cases, the placebo response becomes nil. When we see less severe cases, the difference, the drug placebo differences becomes minimal or nil. Psychotherapy and severity. This thing I want to highlight. Regarding the impact of severity on the efficacy of psychotherapies for depression, a meta-analysis of 132 controlled studies of various types of psychotherapy found that higher mean baseline symptom scores did not predict poor response. That is, even severe depression can be treated with psychotherapy, monotherapy. That's what they say. Severity was not associated with the differential outcome, but these studies have limitations. The interpretation of these data must be tempered by the recognition that studies most often truncate the range of severity included. They have an upper limit for inclusion criteria. For example, scores more than 45 in HAM-D will not be included in the study and they will be excluded. And then they conclude that psychotherapy is also effective as a monotherapy in severe depression. More studies of psychotherapy than pharmacotherapy of depression limit the upper range of severity. These are all studies aimed at personalizing the management of depression. So some points about the clinical practice guidelines. Combined antidepressant and antipsychotic medication or ECT as a first line of treatment for psychotic depression. CONT. NICE guidelines explicitly state that the clinician should not vary treatment strategies by depressive subtype, though elsewhere they specify that augmentation with an antipsychotic should be considered in patients with psychotic symptoms. The Australian and New Zealand as well as American guidelines indicate that biological interventions may be preferred for melancholia and that light therapy is a first-line treatment for winter depression, though antidepressant medication is also effective. Little research has examined the impact of clinical subtypes of depression on treatment decision-making in routine clinical practice. A survey of the factors influencing psychiatrists' choice of pharmacological treatment found that melancholic and atypical features were rarely the basis for selecting one medication over the another, and that anxiety was the most endorsed feature for selecting a particular medication. In conclusion, several subtypes of depression have been identified. The most clinically relevant of these subtypes is psychotic depression, as there is consistent evidence that it requires specific treatment approach. The melancholic subtype retains clinical appeal, but the evidence supporting its differential response to treatment is not consistent. The treatment implications of the anxious and mixed subtypes of depression remain insufficiently studied, whereas the atypical subtype seems to be less clinically relevant today than it was some decades ago. Overall, this is a research area that requires more systematic attention as a part of the current effort to personalize the management of depression. The APA guideline was addressed that specific treatment for melancholic depression, serotonin and noradrenaline reuptake inhibitors and TCAs. CANMED stated that no antidepressant has been proven to be superior for melancholic depression. Seasonal with somatic symptoms and mixed depression disorders were only addressed in CANMED. Other guidelines do not even address specific treatment for these depressions. To summarize, there are so many categories of depression, and there is huge variation among the presentation, clinical presentation, treatment response, course and outcome, impairments. So in planning the management, if we have guidelines to personalize the depression treatments, then it will be, we will have a better outcome for depression, I would say. For which we need solid evidence, and some findings are started coming in personalizing the management of depression. So, and the last question, what would be the reason for only 30% of remission rate in study trial at the end of 3 months of treatment with a single antidepressant citalopram? I think with that, I have thrown some light on the categorizing the depression and its role in the management of depressive disorders. So this is not very well clear, hazy, but still this is an area in which you have to concentrate and see the historical findings, the practices which were practiced for about the last 30-40 years, the newer emerging findings, and the future, there will be changes in personalizing the treatment of depression. With that, I conclude my talk on categorizing depression and its role in management. Thank you all. Thank you very much.
Sir, thanks a lot for the fantastic presentation, sir. I think it will be the most fantastic seminar in the Evolve Forum, I would say.
Nurul, your audio is little louder. Audio is not clear. Yeah. Yes.
Thanks a lot for the fantastic presentation, sir. So I would certainly say this should be the fantastic presentation of the Evolve Forum, I would say. This presentation really rekindled the motivation for by applying the biopsychosocial model within the senior psychiatrist or in the early career psychiatrist. Sir. Really a fantastic seminar, sir. Sir, there are many people answered to the question. So shall we discuss the question now, or we can discuss the question later, sir?
You want to discuss those questions?
Yes, sir.
The answers have already been told in the presentation itself.
Okay, yeah.
Isn't it? Huh?
You
want to read? You want to tell me the questions and answers for that?
Yes, sir.
Yes, sir.
Okay. Then I will again share my presentation.
Yes, sir.
So question number 5, question number 1, DSM-5 describes 9 symptoms of major depression. DSM ICD11 describes 10 symptoms of depressive episode. What is the symptom which is included in ICD11 but not in DSM-5? The answer is hopelessness about the future.
Okay, sir. Okay, sir. Dr. Naveen Yadavalli and Dr. Kavita Parthiban answered first for the question, sir.
And question number 2, what is the difference between subtype and specifiers in DSM-5? Subtype are mutually exclusive categories, whereas specifiers are not mutually exclusive.
Yes, yes. Yes, sir. Dr. Mohammad Abita and Srini Vikas then has answered correct for this question.
Question number 3, which drug is claimed to be more effective in preventing seasonal depression? Bupropion XR.
Yes, sir.
Bupropion is answer.
Yes, sir. For that, we will share the winners in the chat box, because people shared both light therapy and bupropion. So I will share the winners in the.
The question is, which drug is claimed to be more effective in preventing seasonal depression?
Yes, sir.
The questions will speak. Sir, I ask. Bupropion.
See, which treatment is claimed to be more effective? Even light therapy is not effective in preventing seasonal depression. It is effective in treating seasonal depression.
Okay.
Treating or preventing. That there is a difference in the role of light therapy. Light therapy is established for treatment. It is not established for prevention of seasonal depression.
Got it.
Okay. Question number 5. Question number 4, whose operational criteria is a model or pioneer for the concept of operational criteria in DSM-3 in 1980? The answer is Feiner criteria.
Yes, sir. Shamini and Naveen answered correct in the first block.
And the last question, it is somewhat a perspective, I would say. It is, what could be the reason for only 30% of remission rate in STAR-D trial at the end of 3 months of treatment with a single antidepressant citalopram?
People answered as a tolerability.
Tolerability?
And one answered as a diagnostic way. The two answers that we got in the chat.
Diagnostic?
Diagnostic way.
Yeah, that should be the answer, because maybe there is a group heterogeneity among major depressive episode in which a single antidepressant produces only 30% of remission. The way in which the diagnoses are made and categories are created may be the reason for only 30% of remission rate in STAR-D trial. That should be the answer.
Yes, sir. Then I think we have completed all the answers for the questions, sir. For the participants, now the forum is open for any questions.
Nurul, you note down the people who responded.
I have noted down all the winners.
Okay. We can inform the winners. You can take 2-3 questions.
Yes.
3 questions. The chat box.
Hello.
Yeah.
Yes.
Dr. Pani, Dr. Malayapan, good evening.
Dr. Sabita, good morning.
Good morning. Yeah, that is an extensive lecture. That was very thought-provoking, actually. We learned some new things, actually. ICD11 still not gone through properly, I think. That is the thing. See ourselves as teachers, that's the thing.
Okay, madam, your
I
audio
want to
is
know what is the difference between, we have another entity like mixed depression in the two. Bipolar 2 as well as
Madam, your audio is not clear, madam.
Madam, bipolar 2,
seems
there
to
were
be the
previous,
same. See, we have a mixed. What is the difference between the two? Do it.
previous episodes
yeah,
of
I'll put it in
hypomania. Previous episodes of hypomania makes it as a bipolar 2. And there were no previous episodes of hypomania, but in the depressive episodes, few features of manic symptoms are present, then it becomes mixed depression.
Then that becomes a mixed type, no, sir. Bipolar 1 mixed
yes,
type.
Yes, but no, madam. It is a depressive, major depressive episode mixed.
Major depression with some many manic features.
Yes.
It's really
mixed
yeah,
specifier.
it's really confusing, sir. Okay,
mixed
right.
specifier. There were no clear-cut episodes of hypomania. If there were hypomanic episodes, then it goes as bipolar.
Okay.
Bipolar 2. If there were no hypomanic episodes, only episodes of depression in which there are few manic symptoms, then it becomes depressive episode, major depressive episode with mixed specifier.
Is that so confusing, sir? Sometimes
no confusion. Later on, they may turn as
bipolar. That's what
later on they may turn as bipolar, but as of today, we got to say as depressive episode with mixed specifier.
Okay, sir. Okay.
Nurul, can you read some questions from the chat box? Nurul, yeah. Unmute and read some questions from the chat box.
Yes, sir, I am ready. I want to know what about the classification of depression as mood disorder versus thought disorder. Bracket Beck's model in understanding psychopathology.
Primarily, depression is a mood disorder in which thought disturbances can also occur. When thought disturbances is present significantly, it becomes psychotic depression. Primarily, depression is a mood disorder. Predominantly, primarily. In any psychiatric disorder, other symptoms also can occur. So, when there is a prominent mood disturbance, thinking also will be disturbance. Mood and thought are interrelated to each other. When we are sad, we will have negative thinking. So that cannot be called as a thinking disorder. That can be called only as a depressive cognitions. So mood is a primary disturbance in depression, in which there can be disturbance in thinking also. When the thinking disturbance becomes prominent, we will call it as a specifier psychotic. It's psychotic specifier. We should be very clear. Depression is a disorder of mood. No second thought on that.
Sir, I have one question, sir. So in the classification that you have mentioned in the presentation, sir, two things I want to ask in addition to the classification. So one is the premenstrual dysphoric disorder, PMDD, and other one is the DMD, dysphoric mood dysregulation disorder. The DMDD is different, but in terms of PMDD, so if you look into the biology, the hormonal causes are there. So if you want to personalize the treatment plan for the PMDD per se, they have depressive symptoms only a very specific phase of their cycles. So in that context, taking SSRI as a first step, taking psychotherapy as a second step, taking hormonal treatment as the third step. So how do we actually personalize that?
SSRI as a first step. What is second step?
SSRI, psychotherapy, and hormonal treatment models. So
I think the guidelines do not give us
symptoms
solid
4 to 5 days before the menstruation.
Yeah. So for many clinical questions, we don't have solid evidence in our guidelines.
Yeah.
We practice, but we cannot speak on the grounds of evidence-based medicine and say that this treatment should be given for this premenstrual dysphoria or dysphoric mood disorder. We will be basing it on the we will be treating many times in psychiatry, we will be treating without evidences, I would say. So it is up to you to decide, and your clinician's choice to say to choose SSRIs or psychotherapy or hormone. I think hormone therapy is not accepted, is not considered for the management of premenstrual dysphoric disorder because of its side effects, because of the adverse effects of hormones. That should not be advised, I would say. Antidepressants or psychotherapy, SSRIs and psychotherapy, it is your choice. Hormone, I think we have negative evidence to hormone treatment. I think so. I'm not very sure.
Sir, for this kind of cyclical mood symptoms, putting the patient on SSRI for a long time, even if you start SSRI, it will take, as per evidence, 1 or 2 weeks to act. So in that context, treating the cyclical part makes really a great challenge in clinical grounds. So that's what I am trying to ask.
We usually, when there is a significant premenstrual dysphoric disorder, SSRI, if there is a need to prescribe SSRI, it has to be taken on a continuous basis. I don't think it has to be prescribed at that or before the time of menstruation. It has to be taken continuously.
Correct.
If there is a need for pharmacotherapy.
Sir, one question. If we consider the symptom heterogeneity in depression and the need to tailor treatment to get best response, is it safe to say that patients having switch after starting antidepressants in the first depressive episode could do better if we could tailor the treatment to their need?
I could not get the question. I could not understand the question.
It's a big question, right, in the chat box. So, by Mauryadeep.
If we consider the symptom heterogeneity in depression and the need to tailor treatment to get best response, is it safe to say that patients having switch after starting antidepressant in a first depressive episode could do better if we could tailor the treatment to the need? I mean, does it mean they did not require antidepressants for treatment? If there are ways to identify bipolarity in the first depressive episode, it will be better. But as of today, we don't have any biological, psychological, or clinical, or any other parameters to predict bipolarity in the depressive episode. So it may come in the future, but as of today, it will be only a trial and error basis. There are some clinical clues to say that it may be bipolar, but we don't have definite when there is a family history of bipolar, when there are psychotic symptoms, when it is a young male, abrupt onset. These are all pointers towards and racing thoughts. These are all pointers towards bipolarity. For mixed, that's why I told you in mixed depression, you have to treat them with atypical antipsychotics rather than antidepressants. In the case of depressive episode, if bipolarity is suspected, then we have to be cautious in giving antidepressants. Yes, we have to be cautious. But right now, we don't have solid evidence to predict who is going to be bipolar in the future and who will remain as a unipolar depression for the rest of their life. We cannot categorically declare on that prediction. We have to wait and watch only. It will be better if that is available. Am I right? Have I answered the question?
Mr. Mauridi, you can unmute and you can tell.
Yes, sir. Actually, that is what I was looking for. Some of those, as you mentioned, we also have in some papers mentioned as pointers for bipolarity, but still we see many patients who do not have those pointers end up having switch. So that's what I was curious about, whether we have any need.
Sir, considering the personalized treatment for depression, so what is your take on the adequate trial, the 6 weeks, 8 weeks, 12 weeks? So how do you take this, the duration as a criteria for the resistance or no response? So how do you feel?
Duration 6 adequate treatments.
Yes, sir.
Yes, antidepressants have a bio-lag period, and a period of 6 weeks is enough, is necessary to say that drug is not working. We cannot say that, declare that in 2 weeks or 3 weeks. We have to give the time for the antidepressants to act.
Yes, sir. So
dosage and treatment and duration of treatment are necessary to say the drug is not working. But in study, it was 12 weeks.
Yes, sir. My question is, sir, example, if you take the case of adjustment disorder, the patient might be having a clear-cut reason with which they develop a depressive or anxiety or mixed polymorphic symptoms of neurosis. So example, the stress is still there and our drug is not working for about 6 weeks. So during this condition, whether we can take a call on continuing the drug for some more time, or we can consider it as a resistant, we can change the drug. So that's what my question is. So if you feel the stress is still on and we are taking a call on treatment resistance after 6 weeks with the existing drug. In this context, whether can we wait for some more time or we can still change the drugs? So
if it is primarily a reactive depression, then I think antidepressants have little role in my view, in my personal view.
Yes,
the treatment should be psychological.
Yes.
It should be psychotherapy. You can give one drug for 6 weeks and you can switch over to another drug after 6 weeks. There is nothing wrong in switching as per the guidelines, but you need not continue the same antidepressant beyond 6 weeks when there is no response.
Okay.
As per the guidelines, we have to give an antidepressant.
Yes, sir, correct.
Either you optimize or you switch depending upon the response. You either increase a dose or switch to another antidepressant after the 6 weeks.
Yes, sir. Yes, sir.
But it has to be combined with psychological methods.
Yeah, exactly.
Nutraticals. One more question by Dr. Vishnupriya.
Vishnupriya, actually, any role of nutraceuticals like DHA, EPA supplements in treatment of depression?
Tetrahydrofolate is an established augmenting strategy. Apart from that, nutritions have no role in the management of depression as far as we are concerned.
But for schizophrenia, the couple of fMRI and myelination studies are available, sir, for prodrome schizophrenia before EPA and after EPA. So what's happening in the brainstem or myelination tracts. So in case of prodromes, for schizophrenia, it is somewhat available, but depression is not there, sir.
No, no. Even after the onset of depression, we are not able to say with certainty.
Okay.
We cannot say with certainty this individual, because of this finding, is having depression. We have not reached that stage.
Okay.
So there is no question of before the onset.
Exactly.
Thank you, Malayapan
These
sir.
findings cannot be translated to clinical practice. Even in prodrome, I would say. Even in prodrome. If a finding is present, we cannot declare that this boy requires antipsychotics.
Yes,
we have not reached that stage.
Yeah.
Nurul, any more questions in the chat box? One question you can take. Final questions.
What's the role of life-changing insights we get through psychedelics in preventing depressive episodes?
What is the role of life-changing insights we get through psychedelics in preventing? Psychedelics, you mean LSD?
Yes, sir.
Huh?
Yes, sir. He is asking about that already.
I think psychedelics in psychiatry, I don't personally believe, and it should not be used as a rationalization for initiating those substances. As a psychiatrist, I will not advise psychedelics in any way to, even if it is accepted as a standard treatment in any country, I will not prescribe psychedelics to my patients. No, I will say no. Because of the risk of destruction to the brain. No psychedelics.
In the there is one point from my side, sir. In the recent conference on obsessive compulsive disorder held in NIMHANS, it was a similar Jubilee conference. So there was one topic called have you really emerged in terms of treatment resistance, treating treatment resistant OCD? So in that, Dr. Janardhan Reddy has done a detailed review on what is working and what is not working. So in the final summarizing comment, he told that, so with all these failed methodologies, either as augmenting strategies from antipsychotics, glutamatergic agents, and NABS, he concluded a sentinel variety of treatment which helps improvement, gives improvement in all the phases of OCD is cognitive behavioral therapy. Because this kind of behavioral imprinting methods for the day-to-day life events makes really a neuroplastic change in the brain rather than simply playing with the augmenting molecules. So just I remember after your presentation in this context.